Good afternoon, everyone, and good morning to those joining us on the West Coast. I'm Laura Tobler from the National Conference of State Legislatures, and on behalf of NCSL, I would like to welcome all of you to today's webinar, States Help Veterans Access Health Benefits and Save Money Too. This webinar will provide an overview of efforts in two states, Washington and California, to connect veterans with the military health benefits that they are entitled to, which also saves money for Medicaid. Our speakers will provide valuable information on programs in their state, as well as discuss the role of state legislators. Our webinar today will conclude with a question and answer session. Please note that you will not be identified when you ask a question, nor can other participants see what you have typed. As a reminder, you may participate by clicking on the Q&A button and typing your question. NCSL will post the PowerPoint presentation and an archive of the webinar on the NCSL website. The website is on the screen right now. Today, we are very fortunate to have two experts joining us. Washington's Bill Allman will be our first presenter, followed by Manuel Urbina from California. At this point, I'm pleased to introduce our first speaker. Bill Allman is currently the Veterans Benefit Enhancement Program Analyst Department Liaison within the Washington State Health Care Authority. He also serves as the Washington State Representative for the Public Assistance Reporting Information System, otherwise known as PARIS, and is the President of the PARIS Board of Directors. Mr. Allman has 29 years of experience working in Washington State government. In addition to two innovative ideas that were selected for inclusion in the Governor's Blue Book, the Veterans Enhancement Program was awarded the Governor's Award for Customer Service and was selected by the National Governors Association, the American Public Human Services Association, the Council of State Government, and Governing Magazine as a best practice. Please go ahead, Bill.
Well, thanks, Laura, and good afternoon or morning, whichever it is for the participants today. My name is Bill Allman, and I'm going to kind of give you a brief overview for the next 25 minutes or so, at which time Manuel Urbina from California will then give us the California perspective of our project. In today's session, I'm hoping to not only give you the overview, but also kind of give you an idea of how PARIS, the Public Assistance Reporting Information System, the quarterly data is utilized to identify the referrals for the military-related benefits that we're going to speak to, and of course how the project leads to the state Medicaid savings, while at the same time facilitating much-needed veteran outreach, which has not been, I would say, the best at this point. And I want to say why it's needed, because I think that's important. That you'll see the first article there is a link to an article, and it says Veteran Outreach Lagging. And what essentially that article says is 59% of veterans have little or no knowledge of benefits that are available to them. And that may vary, because there was another study that was posted that reflected that only 27% of veterans that were eligible for monetary benefits were actually receiving them. So, you know, I think that that's rather telling. And the fact that the veteran population between the age of 65 and 85 will be growing somewhere between 10%, 23% respectively over the next 15 years or so. So I think it's important, particularly for long-term care. And with that, I'll give you a little history briefly. In 2002, I met with an elderly spouse of what turned out to be a veteran that was on public assistance, long-term care-related Medicaid public assistance. And, of course, she indicated that she got a bill from a state recovery, which, as a financial eligibility supervisor in the long-term care area, I guess I'd never seen those, but there was one in her hand, and She indicated that it said that she owed $80,000 because that was the Medicaid utilization of her spouse, and she wondered if any of that was military related, and was that was already taken off, or did that include that? What the case was, and I happened to look the case up before she even came into the office, and I noticed that we weren't aware of any military-related coverage, and that often happens when you're in long-term care Medicaid, because usually a spouse or a family member or a POA usually applies for them and is not really aware of all the benefits that they may be entitled to, don't list any third-party medical coverage they may have, maybe not even be aware of it. And so because long-term care Medicaid is the only Medicaid that's subject to a state recovery, I think that it's important to identify those that may have any coverage that's military-related to reduce whatever Medicaid expenses that they may incur over the course of the long-term care Medicaid eligibility. We noticed, which is one of the reasons why we started with identifying the long-term care as where we wanted to begin the program, is because there was a marked increase in long-term care Medicaid expenditures, and quite frankly, I think it's going to increase somewhere in 200% in the next 5 years. It's growing, by leaps and bounds. And we know that 50% of all males over the age of 60 are veterans. And as you see, when we get into that older demographic, because of the draft and what have you, there's a larger percentage of veterans that, are in that 60 and older category. A couple things that you should know is this isn't really so much as something, gee, I wish you would take heed to this and do this program. This is really something that is supposed to be done already, because I list the CFRs that speak to Medicaid being the payer of last resort, and the other statute that indicates that there's a mandatory pursuit of any third-party resource or liability that may exist. Now, it kind of reads to the one section in that statute that says if you have a means with which to reduce your need for state public assistance, you must pursue that. So it lists veterans benefits. It says may be but not limited to, and it'll say railroad benefits, unemployment compensation, veterans benefits. So, and I looked up many states that have their state statute that reflects this, and many states list veterans benefits, so it's really required that you identify veterans at application and refer them to the potential benefits that they may have. We found that we had quite a few veterans that not only were we unaware of, but that have never been referred, for veterans benefits. So we thought it important to establish a partnership with the state agency that's responsible for being a liaison between federal VA affairs and the citizens of the state, and of course us being a representative of the clients. So we established a partnership, and we began a pilot project, and that pilot project was started approximately late 2003, early 2004, and it was in a county. We took one county that we thought was more of an average, I would say, of our state demographics regarding veterans. 15% of our general population, for example, are veterans, and in this particular county, which is Clark County, it pretty much reflected the state demographics. So we established the partnership, and we were given permission to go ahead and do a 2-year pilot. We felt that the agency goals for both of us would be to improve client services, veterans and their families, reduce the state recovery for the Washington veterans and their families, reduce Medicaid long-term care-related expenditures, and share data to identify clients potentially eligible for veterans benefits, and the roles that each of us would have during the course of our pilot. And the pilot was extremely successful, and I'll say that we managed to refer quite a few clients, not only at application, but as a result of our participation with Paris, which we discovered right at the outset of our project, because we knew we wanted to identify an area that were perhaps going to give us some linkage to the Veterans Administration, and maybe even the Department of Defense if we were lucky. And we were indeed lucky, because it was Paris that was referred to us, and we joined in 2002. And a few notes about Paris. It's a federal-state partnership, provides 52 participating agencies, state agencies, with detailed information and data to assist them in maintaining program integrity and, of course, detecting improper payments. That's particularly in the interstate match. But the data comes from the Department of Defense. That's the first match that we do, and that includes active duty military, reserve military, retired military, those that are in the Office of Personnel Management, and civil service employees, and retired civil service employees. We also have one with the Veterans Administration, and this is veterans and survivors of veterans with current VA monetary claims or a history of VA monetary benefits. And last but not least, the interstate match. And, of course, this is matching Social Security numbers with the other 51 states and territories that Paris has under its jurisdiction. And I think CMS sent the letter, I'm trying to remember, it was October, I think, of 2010, that was sent to all the state Medicaid directors, and a link is provided there that would take you directly to the letter, and it states that all states need to participate in Paris with regard to the interstate match, which when you submit Social Security numbers for all active clients that are receiving public assistance in a respective state, it will link up with another state that has someone with that same Social Security number also receiving benefits there, thereby reducing the many clients that happen to be receiving assistance in more than one state. I might add that it's very beneficial from an interstate match perspective to work these matches, because we find that 51% of our interstate matches were children's medical only cases, and they are, perhaps let's just use Oregon as an example because it's a border state, but we certified them for a year, and we found them on the average of the seventh month of their eligibility, and they were really in another state, and we're paying a premium of $129 a month for each child that's on assistance. And if they're no longer in our state, then it would, of course, behoove us to close the case and save state dollars, Medicaid expenditures, by closing the case properly and timely. How we utilize Paris is we send all of our active recipients on public assistance, and we send all of the financial responsible assistance unit members, maybe parents on children's medical cases, or a spouse on a long-term care case where the client happens to be his wife, or vice versa. And we found that the benefits of utilizing Paris data was for health insurance identification for TRICARE, CHAMPVA, veterans health care, and, of course, and last but not least, maximizing monetary VA-related payments. I want to start with the federal file match because for those of you that may, develop a partnership with your state VA, and there's that time frame where you haven't developed a partnership yet and you want to get started and you want to show some action in the project area, we start with the federal file match. And we primarily use federal file match in addition to comparing income amounts with those amounts that are coded in our eligibility system. We also use the federal file match to identify TPL responsibility third-party liability, primarily TRICARE recipients. So we look at the following categories, which are identified with a data element and a data field on the return file sent to us by the Department of Defense. And we see there are reservists. We look for reservists on active duty more than 30 days, retired reservists and family members, active duty and retired service members, spouses and unmarried children, including stepchildren of active duty or retired members, and widows and widowers and unmarried children of deceased active duty or retired service members. All of these categories have TRICARE eligibility, which is a federal program, a third party that is absolutely wonderful coverage. I wish I had that coverage myself, to be honest with you. And what we do is we match the number of those TRICARE sponsors with all of our Medicaid recipients that come through on our match with the Department of Defense here. And what we do is we merge all of the military-related categories that have a data element that shows those respective categories in that last slide, and we merge it with the carrier code in our MMIS system, which is Provider 1 now, that identifies anyone that has TRICARE coverage that we're aware of. For example, our code is HI50. And so we say, okay, this is all of the clients that we feel have TRICARE eligibility by virtue of their military-related status, and we merge that with our HI50. And whichever our coordination of benefits in our MMIS system are not aware of, we say, okay, and this is an average, somewhere in the vicinity of 225 to 250 clients per quarter are referred to our coordination of benefits as having potential TRICARE or should have TRICARE coverage that our third-party screen reflects us not being aware of it. At that point, our coordination of benefits folks will send out a letter and notify the clients and immediately code the TRICARE coverage once they confirm them in DEERS. I think it's important. Some people say, well, we get that once a year match with the Department of Defense and DEERS, but by doing it quarterly, you're able to promptly go back retroactively the 12 months that you're allowed to recoup any Medicaid expenditures that the client may have incurred, which, believe it or not, I mean, is very, very lucrative for Medicaid purposes because I know some states have contractors that do the pay and chase for retroactive, but there are a lot of expenses that Medicaid has paid in that 12-month retroactive period that are extremely lucrative. We have the Veterans File Match. This will show anybody. This is our active clients that we're looking at. And so what they're sending us back through their VetsNet Treasury screen, that's a screen that the VA is essentially sending us data elements from, and it matches the veterans or a payee's, most often a spouse if other than a veteran, against their Social Security number. So what we do is when we get back all of our clients that the VA has identified in our match, or Social Security number match, we want to at first and make sure that everyone is enrolled into the VA healthcare system. There are a number of veterans that could receive their prescription drugs without the need of a VA doctor even prescribing the medication. Their own physician, as long as they're state licensed, could prescribe that medication. And that would be for those receiving aid attendance, for example, or housebound allowance, and those veterans receiving a 50% or more service-connected compensation, or a disability, if you will. Now, there are two types of clients that are receiving benefits through the VA. One is compensation, which is a service-connected disability-related payment, or a pension, which is needs-based, usually a veteran with wartime service, usually indigent with little or no income, and they qualify for a pension. We also identified CHAMPVA. It's probably the little known coverage, I would think, of all the coverages. CHAMPVA is for a spouse or a child of a veteran that is totally disabled or 100% service-connected disabled, and or could be a surviving spouse or a child of a veteran who died from a service-connected disability or is rated totally and permanently disabled. Now, what Paris does is they have an identifier that says these are all your compensation cases, and then there's a certain kind of compensation that Paris identifies as receiving DIC or indemnity compensation benefits, and these are spouses of a veteran that was 100% service-connected disabled and, of course, fall into the CHAMPVA category. They have this coverage that I'm telling you 90% of the time are totally unaware that they have this coverage, and for whatever reason, this isn't listed on the Veterans 100% Disability Award Letter, so I don't know really how a spouse would know about this coverage if not for our ability to identify them through this Paris match. Of course, we want to maximize all the monetary benefits that the VA file identifies. These would be things like Medicaid veterans. We'll see many $90 payments. It's because when a veteran goes into a nursing home, let's say I'm a veteran with a pension, I go into a nursing home, I'm reduced to $90 by the VA because they say I don't need the full monthly benefit. You know, they give me $90 for my personals and incidentals, with the understanding that, well, Medicaid's matched anyway, so, you know, they don't need that full amount. And when a veteran gets out of a nursing home, and maybe he goes home to our waiver program, which is called COPES, where a state has a care provider go in, where the state pays the care provider, or an assisted living facility or adult family home, anything other than a nursing home, that $90 payment is supposed to go back up to his regular amount. And, of course, the veteran has to inform the VA that he's out of a nursing home. So oftentimes this doesn't happen, and they will continue to receive $90 as opposed to what they really should be receiving as the regular monthly benefit. And we identify that in the Paris match, $90 cases no longer in a nursing home. Also, zero income amounts. There's many zeros. We compare the reason code for them receiving zero amount, and we concentrate on the zeros that reflect them not turning in an eligibility review, and many times that's overlooked for whatever reason, and we're identifying those, and we're sending all of these referrals to our state Veterans Affairs folks who do the actual contact of the client and let them know what benefit they're eligible for, or like in this example, you're not receiving anything right now, you didn't turn in a review, and many times they're not aware of it because they have direct deposit. We want to make sure that we identify the 70% and higher service-connected disability veterans because they are eligible if they have a VA-contracted facility provide them care. Not needing Medicaid at all because the VA has said that these folks will receive all of their care through the VA, and I guess I should say a lot of these veterans are not aware that they may be in a non-VA contracted facility with a VA contracted facility not far away, and our state VA will refer these clients to our state VA that we identify in the Paris match and say, this client, if they move to a VA contracted facility, maybe they could be, off Medicaid, and could you facilitate seeing if they would like to do that, explain where this facility might be located, the nearest VA contracted facility. They could continue to what they'll do is instead of only allowing $160 to these specific veterans in a facility while they're in a non-VA contracted facility, they allow them to keep 160 of their, let's say, $2,700 100% disability payment that they received. The rest goes to the cost of their care. But if they move to a VA contracted facility, they get to keep all of their income every month, and the VA provides all of their medical, so there's really no reason for them to be on Medicaid at all. So we identify those that we feel might be eligible for that, and of course refer them to our state VA for contacting the client. Of course, we identify Vietnam-related veterans that may be eligible for an Agent Orange settlement, and more importantly, the aid and attendance benefit that if you Google aid attendance right now, you're going to see many elder law attorneys come up on your screen, and I think this is a little-known benefit that your clients are eligible for. Generally speaking, the definition to be eligible for aid attendance is in need of a third party to care for you. So by isolating all of your long-term care Medicaid clients, and Paris lets you know through a data field whether or not that client is receiving aid attendance already with their benefit, well, the ones that aren't, that are long-term care related, are eligible for, could range from a spouse of $417 extra a month up to a veteran of $692 a month. And unless the veteran asks for this benefit and can substantiate their third-party need, which is an institution, a care provider, or what have you, they don't receive that benefit. So why have an elder law attorney facilitate it and, take whatever it is that they'll take from a veteran to facilitate the process of them receiving that benefit? This is essentially a cost avoidance graph. In fiscal year 12, it says projected, but the final numbers were a savings of $6.2 million. Over the course of our project, we've saved in excess of $40 million in Medicaid expenditures as a combination of third-party conversion, monetary benefits for increased, reducing the amount the client has to pay for the cost of their care, and of course the subsequent Medicaid expenditure. So it's been extremely lucrative as far as Medicaid, but more importantly, we've provided benefits for veterans and their families, somewhere in the vicinity of 15,000 that prior to this program were not receiving benefits that they were eligible for. And with that, I guess I'll move it to Manuel to give us an overview, I guess, of California.
Thanks very much, Bill. Next, we will hear from Manuel Urbina. Mr. Urbina has been a member of the Paris Board of Directors since 2010. He is currently responsible for leading a program integrity and security operation in the California Medicaid program. Manuel has worked in the Medicaid policy field since 1999 after earning a Bachelor of Arts degree from the University of California, Davis. Manuel is currently responsible for advancing program integrity in Medicaid eligibility determination policy. Additionally, he is responsible for leading California's implementation of the Public Assistance Reporting Information System, the PARIS system that we've been talking about. Before I turn it over to Manuel, I just want to let you all know that we're receiving your questions. They're in a queue, and we'll address Q&A right after Manuel's comments. Please go ahead.
Okay, good afternoon, everyone. Thank you for the introduction. Before I get started, I just want to thank the NCSL for putting on this presentation. They really do a good job with their webinars, and it's a privilege to be a part of it. Like was mentioned, I have been working in Medicaid for 15 years, but the last 5 years I have really focused on, program integrity initiatives and reducing improper payments. Now, being interested in program integrity, that's really what led me to Paris, and I've had the privilege of serving on the Paris Board of Directors since 2010. So since this is a national audience, I thought it would be important just to talk about California for a minute. This slide has a colorful map of the state here. These are basically all the counties in California. And you might recognize some of the major population centers there towards the southern coast, such as Los Angeles, Orange, and San Diego. And towards the north area, you might see the San Francisco Bay Area. You might recognize that. And the Central Valley, of course, is where I'm located here at the state capitol in Sacramento. There's also a flow chart on this slide. It gives an organizational sense of how public assistance programs are organized in California. You can see the Medicaid program over here on the left, which is where I am, and SNAP and TANF are over in another agency. So my experience really has been over here in Medicaid, trying to help veterans enrolled in our program, to get better benefits from the federal VA. Okay, so you've heard a lot about what Veteran Benefit Enhancement is all about. I'm going to go ahead and describe, California experience and the role of the legislature in that. Give you a little bit about our pilot program experience, and then discuss what's going to happen in the future, including potential expansion. So, legislatures, they can play a powerful role in getting a veteran benefit enhancement effort going in their state. That was my experience here in California. Most legislative bodies have some type of independent, nonpartisan advisory organization, and maybe a good example at the federal government level would be something like the GAO, the General Accountability Office. And in California, we do have something of that nature, the LAO, the Legislative Analyst Office. And, most states do. I know Texas definitely does. Their Legislative Budget Board, they took a look at Paris a couple of years ago and recommended implementation in Texas. So, legislatures, they do have the ability to analyze new projects and recommend implementation. In California, this happened in August 2007. The California LAO, they published a supplemental report language that basically required the state Medicaid program to develop an implementation plan, so like pilot counties and identify any necessary resources. The next step is obviously statutory mandates. So after that report was published, the very next year, the legislature, proposed a bill requiring a 2-year pilot program. That law was enacted, and the state Medicaid program was required at that point to pilot the program from 2009 to 2011. And we were required to submit a report to the legislature when we were done with the pilot. So another experience we had was, legislative oversight and the call for public hearings. So in California, the Assembly Budget Committee called a hearing last year. They wanted to review our results of the pilot program. They wanted to ask the administration any questions about potential for expansion. So the legislature had a significant role here in California doing all these things on this slide. A pilot program is, a sound idea always, just to test the effectiveness of a project before committing to the investment of full implementation. So in California, we were required to conduct a 2-year pilot program and evaluate those results. That was from 2009 to 2011. The scope of that pilot was somewhat narrow. First of all, the pilot was only conducted in 3 out of the 58 counties. We picked 3 counties. We picked them because they were in areas that had federal VA medical centers in operation within the county limits. And so that the thought was, the Medicaid beneficiaries, if they decided to get care from the federal government instead of the state Medicaid program, the facilities were nearby. And the pilot focused on certain Medicaid beneficiaries. That is, we didn't, try to work all 10 million of our Medicaid beneficiaries. We focused on certain high-cost beneficiaries that we felt were most likely to qualify for full VA health benefits. And we focused on individuals that we thought were eligible for an increase in their income, either their pension or compensation. So we focused narrowly on a group of individuals. The statute required that the pilot, that the state Medicaid program partner with a state Veterans Affairs Department for outreach services. So in California, we were already working, the Medicaid program was already working with the state Veterans Affairs Department, and under the pilot, outreach services were extended to focus on, Paris-identified individuals. When the pilot was over, a legislative report was produced and delivered to the chair of the Legislative Budget Committees, and the report showed that we did achieve the pilot objectives, and it really shows great potential. During the pilot, the savings amounted to $1.4 million in total cost of goods savings. And, that we think that amount's pretty high, considering that was only 3 counties and a small number of individuals. 1.4 million for 3 counties. So a lot of people read that report and like, wow, there's a lot of potential there. Okay, veteran benefit enhancement projects, they're clearly very good for the interests of veterans. They get better care, more money, and we get them into a better situation. However, from perhaps a legislative budget perspective, the greatest thing about these efforts has to be the cost-benefit analysis. In California's pilot program, there was very little investment of resources, and we had a huge return on investment. You do need resources. You do need people to filter the match results and analyze the results and perform the referrals, and most importantly, you need people to conduct the outreach services themselves. However, the savings from avoiding these high-cost services that should be borne by the federal government are very considerable, and they far outweigh any cost you're putting into it. So, given that high return on investment, the California Legislature is clearly eyeing expansion of the pilot program to additional counties. In fact, the Legislature has proposed a new bill this year, 2013, that would require that very thing. Assembly Bill 1124 would strike out the statute that called for the pilot program and replace it with a new section that requires a permanent statewide program. To summarize, the Legislature, has a powerful role and can serve as a catalyst for implementing a veteran benefit enhancement program. I've mentioned the experience in Texas and California, but there's other states as well. The Commonwealth of Virginia is submitting reports to their legislature right now regarding their veteran benefit enhancement projects. The legislature authorized 3 positions for that effort. The state of Wisconsin announced last year that they would start a veteran benefit enhancement project. I read the reports of the legislature, and, it's a real success story. One other topic I think is real salient right now is health care reform, or the Affordable Care Act. Medicaid expansion is scheduled to occur in 2014. Many uninsured veterans will attempt to enroll in Medicaid to meet the individual mandate requirements of the Affordable Care Act. So many observers, including the Center for Healthcare Strategies, recommends that the state Medicaid programs, they try to work with these veterans and let them know that they're eligible for free health care from the VA. So instead of, feeling this individual mandate, I got to get insured and, applying through an exchange and going into Medicaid, we should be thinking about trying to talk to some of the veterans and say, look, you can get free VA health care. It's very high quality. You won't have to pay any of it back. And so that's definitely a consideration for states going into 2014. And that concludes my remarks from a California perspective, and I'd like to turn it over to the meeting facilitator.
Thank you so much, Manuel. I would like to thank both of our wonderful speakers, Bill Allman and Manuel Urbina. Remember that we will have an archive of this webinar, including access to the PowerPoint presentation up on NCSL's website in about 5 days. So maybe by the end of this week. You can get to it by going to www.ncsl.org and clicking on meetings and then webinars, or you can get there through the link that I showed earlier. Now we'd like to open the floor for participant Q&A. We certainly have gotten quite a list of questions right now. If you have a question, please get it into the queue as soon as possible. As a quick reminder, to ask a question, please click on the Q&A button and type in your question, and remember that the questions will remain anonymous. So let's start. Bill, this question is for you. Our state is interested in exploring whether low-income veterans currently on general assistance could instead be on VA pensions. Does any other state do this? Is anyone using Paris for veterans' pensions as well as health care? This is a long question, so I hope you're taking notes. Is anyone using Paris to screen their non-Medicaid public assistance populations? Finally, is a Social Security number necessary, or could the service number be used instead?
Well, I think in many cases, the Social Security number is the service number, with the exception of veterans that maybe became military active duty folks, I think it was 1970, they started using Social Security numbers. So in many cases, Social Security number is the military ID. But that said, for general assistance clients, and we looked at this, we found that 9.5% of our general assistance clients were potentially eligible for veteran-related benefits. And, for us at the time, general assistance clients were receiving a maximum of $339 a month and state-funded only medical assistance. And, of course, by looking at, for example, a pension, because they would fall into that category as perhaps being needs-based, no income, very little income, and being disabled per VA criteria, they would be eligible for a pension, which would at least be $1,000 a month, and much more than any state assistance that they would receive. And certainly, this is a benefit that they're entitled to. And I might add that I ran through the presentation because, I didn't want to go over, because I know there were a lot of Paris board members that were saying, no way, you could do a presentation in 25 minutes or less. That said, I want to let you know that, of course, we're available for questions and emails if you need any clarification. But bottom line is you should be referring all clients that apply for public assistance to comply with the statute that says if you're eligible for benefits that reduce your need for public assistance, you must pursue them. So in theory, every state should already be referring anybody that applies for public assistance and referring them for the potential of veterans benefits that they may be eligible for. And, the savings, of course, is always a given, but, the outreach that you provide to veterans and their family members is priceless, and savings is a foregone conclusion, because the more military-related benefits that they receive that they're entitled to, obviously the less Medicaid expenditures there's going to be.
Thank you, Bill. One of our participants wanted to know whether or not you were going to show a Paris CARES report and what it looked like. I am going to volunteer you to talk with that person and maybe coordinate sharing a Paris report, or at least explaining one. So the person that asked that question, if you could contact Bill directly. Our next question will go to Manuel. What type of resources are needed for follow-up with veterans identified through Paris Match?
Okay, great question. Basically the way Paris works is that you're submitting a list of your program beneficiaries, in my case, Medicaid recipients. You're sending them into the Paris system, and then you get back a list of your beneficiaries that are known to the federal VA. Now, what we do is we go ahead and filter the list down to a smaller number of people that we think we can conduct outreach services with, and that meet certain criteria, like are they getting $90 and could they get more income that way, or are they eligible for full VA health care? Is a family member eligible for CHAMPVA? Those are all things you want to do with the information that gets. So you need resources to do that work, filtering and to make the referrals. Now, outreach services, we are working with our state Veterans Affairs Department. So they obviously need people to receive the referrals from us and then contact the veterans to let them know that they qualify for more benefits and to help them fill out any forms and to follow through and get back to us on that. So if the question is coming from a state Veterans Affairs Department, once you get the referrals over from the Medicaid program, you should have sufficient resources in place to do the outreach services and to follow up on the match results. And I mentioned Virginia that they authorized 3 positions, and I think Texas was very similar, that resources were provided to the Texas Veterans Commission perhaps to do the outreach services. So that's definitely a consideration when implementing this.
The next question actually is related to this. It's specifically being asked Washington. Was Washington able to justify additional Veterans Services officers to work this program?
You know, I kind of wanted to cover that in one of the slides, but, you know, I wanted to kind of move along. But, you know, after the pilot, you know, was successful and it was shown that the return on the investment was 8 to 1, our legislature, without the need of real legislation per se, was given the results of the pilot and said, you know, we want to move this program statewide and make this a permanent program. And they authorized 4 FTEs to our state Veterans Affairs, plus seed money to do things like perhaps contract with the VFW and American Legion to assist them with the numerous referrals that we were going to be sending them. Because let's face it, I mean, the state Veterans Affairs, they have to be brought to the table. The party doesn't start until they get to the table. Let's just put it that way. And we were blessed to have a great working relationship with our state Veterans Affairs office, who I think is one of the best in the country. But I think it goes without saying that what they're going to be doing with regard to the referrals that you send them is exactly what their mission is. So they, of course, need the FTEs for the workload that's going to be increased. And I also believe the knowledge that they are able to give the 2.5 FTEs that we were authorized from a DSHS perspective is priceless as well. Because I'll be honest with you, for example, as a Vietnam veteran, I wasn't aware of the Agent Orange settlement and the things, the types of cancer or type 2 diabetes that was a symptom of Agent Orange exposure, and you could put in for a disability and receive 100% compensation. I wasn't aware of that. So while you could do the federal file piece that I had mentioned at the top of the slides without the state VA, I think it's very, very important to contract with your state VA to do the many, many referrals that are going to be facilitated using both the VA file and the interstate match, for that matter, too, as well.
Thank you, Bill. Manuel, one of our participants wants to know if the pilot program, California's pilot program, if a description is available online, and whether or not the reports that you referred to are also available online.
Yes, our full legislative report is on our website under reports, and I don't know if I can get a copy of that to the meeting facilitators, but yes, it is online.
Manuel, if you'll send that to me, we could send it out to the group.
Okay.
Here's our next question. Regarding TRICARE in particular, isn't the onus on a veteran to apply for federal TRICARE benefits? How do states handle scenarios where a veteran is identified as eligible for TRICARE through the Paris match but has not applied for TRICARE through DEERS? Do states simply drop Medicaid coverage in these cases? I guess I'll turn it over to Bill first, and then Manuel, if you want to comment on it, you may after that.
You know, our third party, our coordination of benefits folks, primarily take the referrals that we send them from the potential TRICARE recipients that are identified in the federal match. We identify clients that, in theory, meet the military criteria for coverage through TRICARE, and when we find that they are not identified as having TRICARE in our third-party screen, then, you know, the onus is on the coordination of benefits folks at that point to contact the client to inform them that they have TRICARE eligibility, and it would be the same process that they would do for finding a client at Blue Cross and never reported it, or any other coverage that was a coverage that's primary for Medicaid. Because, again, Medicaid is the payer of last resort, and we, I think, want to make sure that we refer all the potential TRICAREs, primarily because this is a legitimate third party, covers 80% virtually all your skilled nursing care, doctor's visits, 100% of your prescription drug coverage. So, I mean, it's an extremely good health coverage. And, you know, the clients, many clients are unaware that they have eligibility for TRICARE, or feel like it used to be called CHAMPVA, and they used to be required to go on a military base back in the late 80s, early 90s, before it became renamed TRICARE, and it became a national network that was more coordinated and, you know, is contracted out many of their coverages, and you could get your prescription coverages, for example, through many, many pharmacies, the same pharmacies that they would even use their Medicaid. So that is mandatory, but for VA healthcare, we still don't consider that to be a mandatory, you must before Medicaid coverage at this point.
Manuel, did you want to add anything?
Yeah, I definitely concur with that. I mean, what we do, we definitely are finding a lot of undiscovered third-party healthcare coverage in TRICARE, and, you know, just active duty, you know, individuals, you know, a typical situation is, you know, an 18-year-old enlisting in the military or something. You know, they're leaving the family home, but the family, you know, perhaps doesn't report that change in circumstances to their Medicaid worker. You know, this person's left home, and so we continue to make the monthly capitation payments without knowing that the person is left, and their health care is completely taken care of in the active duty military. So the PARES report, you know, shows those to us. You know, we'll get 100 of those every quarter of, you know, active duty Medicaid beneficiaries. So that's how we start. That's what we're focused on is the undiscovered. But as far as people who are eligible but unenrolled, right now we're just focused on the undiscovered portion of it.
Thanks. Next question. So we have about 5 more minutes for Q&A, and we still have quite a list, so I'll try to get through as many as I can. Would moving a veteran from Medicaid to a service-connected benefit rule out the veteran's family for Medicaid coverage due to increased income? Bill, do you want to take that?
Yeah, no. The veteran, of course, if he was 100% moved to 100% service-connected disability, then, you know, as I mentioned on the CHAMPVA slide, his spouse and dependents would also be eligible for the CHAMPVA coverage. Then he would be getting, you know, comp VA care. I mean, it's 100%. He's Category 1, pretty much carte blanche, all VA care. And his family at that point would be eligible for CHAMPVA, which, well, there's a case to be made for the CHAMPVA coverage is better than TRICARE. And certainly, again, these spouses and dependents need to be identified as, you know, the spouse and dependents of a veteran is 100% service-connected disabled because of this coverage and because it's, way better than Medicaid coverage is, and much more accepted, you know, by pharmacies and doctors, you know, all over the country. In fact, they have a drop-down menu that has a zip code on their website that, you know, even has providers that are pretty much, you know, volunteering, like, hey, look, I'm Dr. So-and-so, and I want to be listed as a CHAMPVA provider. It's very good coverage, and, yes, they're eligible for this CHAMPVA coverage. And, again, it's probably the most little-known coverage of all the military-related coverages. And I might want to just say one thing I forgot, and this is important with all of our returning veterans. The exit interviews that the military is doing, you know, for whatever reason, is not really reaching a lot of the veterans that are discharged and have issues, maybe as PTSD, having a hard time finding employment, don't have health insurance coverage, when in fact they do. Any veteran with 2 years of continuous honorable service is eligible to enroll in the VA healthcare system. And I got to be honest with you, there's no excuse why any veteran that is discharged doesn't enroll in the VA healthcare system because if you're Medicaid eligible or indigent, don't have any income coming in, the VA is required to waive all of their co-pays. So there's no excuse for that whatsoever. And, well, I hope that answered the CHAMPVA related question of service-connected disabled benefits.
Thanks. Manuel, if a veteran is eligible for VA coverage as well as Medicaid and enrolls in VA health benefits, must they receive care through a VA facility, or can they also receive care through a Medicaid provider?
Well, for TRICARE and CHAMPVA, we code that as other healthcare coverage in our system, so that is mandatory. But for the VA system of healthcare, right now it's up to the veteran. And during our pilot, that's exactly what we found is individuals simultaneously enrolled in both. And the focus of our outreach is just to have the conversation with the veteran and say, look, you don't want to be in Medicaid due to a state recovery that, to protect your family's assets and everything like that, because it will need to be paid back, and you get better coverage from the VA and so forth. And we find that most of the time they will just go ahead and voluntarily receive their VA health care instead from their medical care from the VA. And so we monitor that, and so we just show them in a state recovery letter, putting a lien on a home, and it's very powerful. We show them the value proposition, it's just like open enrollment, looking at a couple different plans. Here's what Medicaid covers, here's what VA covers, and they'll see that they get richer benefits from the VA because, at least in our state, we've been cutting back on benefits, and we don't cover as much as we used to, and we have utilization controls, and it's also one of those things is that, VA healthcare is not a handout. It's something that's been earned through their service to the nation, and so that's how our outreach services is conducted, is through the voluntary disenrollment of certain simultaneously enrolled people. But for CHAMPVA and TRICARE, it's mandatory that you use those first.
Thank you. We'll do one more question. Bill, can you tell us if Washington has been involved with identifying clients residing in non-VA-owned facilities and assisting them in becoming certified, authorized to accept VA payments for nursing home care? In Michigan, it appears facilities are mainly contacted by the VA hospitals when they need a nursing home facility for a specific veteran. We are interested in expanding these agreements.
Well, I'll be honest with you. I think every state would love to expand those agreements. I contacted the VA and looked to expand upon the number of facilities that they had contracts with, and was told that they pretty much were at the maximum amount that they had in each state. And, hopefully, maybe there'd be some legislation or a change that would open up more facilities that could be, contacted by the VA. They're supposed to be strategically located throughout the state and be in an area where, we could contact a veteran that's in a private facility without a VA contract and say, if you move to this place 2 miles or 3 miles away, the benefit would be that instead of being on Medicaid and only keeping $160 of your month and the rest go to the cost of your care, you get to keep all of your money, and you can share it with your family members or do whatever, and the VA is going to pay for all of your care. You won't even need Medicaid. And it's important to remember that all the long-term care cases that, we targeted, it's important to know that they have to pay this back or at least be responsible to repay this back. And again, why would we want any veteran to have his estate be responsible to repay something that should have been facilitated through the utilization of any military-related benefits that he may have been entitled to?
And just one footnote on that, the federal VA has proposed sort of easing the regulations would allow veterans to access, skilled home health care services. And that's been a barrier in the past, getting the VA to establish provider agreements, non-VA providers. So we're hoping that eliminates some barriers in the future to that.
Thank you so much. Unfortunately, we did not get through all of the Q&A, but we are coming to the end of our webinar. I will coordinate with the two speakers today to hopefully answer your question via email. Again, I'd like to thank our speakers and all of the attendees for your time and participation in today's webinar. As a reminder, an archive of the webinar will be available on NCSL's website in 5 to 7 business days. Thank you all very much, and this concludes our webinar.